CBT, as you see, I actually have some slides. We don't have time to go over all slides, but you probably have a copy of the slides. So I want to make sure that it's clear to you that this is a very good question, because BDRC is a type of CBT. Right? It's a smaller type of CBT. And like George mentioned, the CBT actually is based on social learning theory, and CBT is concerned with your thinking, what's going on in your mind, how you conceptualize thinking about faulty decisions, and etc. And BDRC is more of a behavioral. So the CBT is sometimes we call it capital C, small b, and big T. All right? And BDRC is small c, big B, and big T.
Oke. Ya, jadi Bapak Ibu sekalian, ini untuk mengklarifikasi lagi bahwa yang namanya BDRC ini adalah bagian dari CBT. Cuma di dalam CBT itu C-nya dalam huruf besar, B-nya huruf kecil, T-nya huruf kecil. Artinya apa? Penekanannya kalau di dalam CBT adalah pada kognitif, pada pola pikirnya. Tetapi kalau BDRC penekanannya pada B-nya, behavioralnya. Jadi C, B-nya besar, T-nya kecil. Jadi behaviornya tuh lebih ditekankan kalau dalam BDRC.
Okay, so if you look, this slide shows the kind of principles of CBT in the substance abuse treatment. The goals are similar. That in CBT we are looking into helping people abstain or reduce drugs, avoiding risks, developing rewarding activities, increasing involvement. This is all the same. That's what we do. And BDRC borrows or based on that, and the contract, for example, or the several communication skills, something that I did yesterday, is walking a person through the finding about activities. It's sort of similar to something that in CBT is called a functional analysis of behavior. It's a kind of a chain of behavioral events. So they are similar. They are more refined and more targeting patients who helping patients with problems that are typical for opiate-dependent individuals. And they are easier to learn. BDRC is much easier to learn than CBT.
Ya. Kita lihat di sini bahwa tujuannya CBT sama BDRC itu nggak jauh, nggak beda, ya sama. Jadi BDRC memang meminjam tujuan daripada terapi yang ada di CBT. BDRC jauh lebih mudah untuk dipelajari dibandingkan dengan CBT. Dan apa yang kemarin dilakukan, yaitu dengan kita meminta dia menyebutkan apa yang dilakukan pada satu hari kemarin, hari Senin namanya, itu persis seperti apa yang ada di CBT yang disebut sebagai analisis fungsional. Ya, kalau Bapak Ibu sudah pernah belajar CBT.
So, this is a good opportunity for me to introduce one important difference between BDRC and other CBT-like treatments. I didn't spend much time walking around here, but in most methadone maintenance clinics or drug treatment programs, when I walk in the first time, I see a big picture that says drugs kill, or they show an orphan children because their parents died because of AIDS, and etc. There's a lot of negative messages, scary messages in most of the clinics, emphasizing trying to make people change behaviors by kind of, emphasizing dangers of drugs. That you will go to jail, you're going to die. They show pictures of people having all sorts of infections or sometimes lost hands and etc. These are negative or scary messages, like on tobacco. I saw it here somewhere that when you sell cigarettes, there's a picture of lungs or of infections, right?
Ya, jadi ada lagi satu hal yang membedakan antara BDRC dengan CBT atau yang serupa dengan CBT adalah BDRC menekankan pada pesan yang positif dari sebuah perilaku. Kalau di CBT itu bisa saja dia menggunakan yang negatif, seperti halnya kalau di poster-poster kita bilang bahwa narkoba membunuh kita dan sebagainya, merokok bahaya ya, menyebabkan kanker dan sebagainya. Nah itu yang tidak digunakan di dalam BDRC.
And traditional anti-drug approaches applied by the police, by the government, by larger societies, basically based on the scary messages, telling people how bad what's the bad negative consequence. You shouldn't be using drugs because they are bad for you, and etc. etc. You're gonna get AIDS, you're gonna get tuberculosis, you're gonna lose your job, you're gonna get arrested. And this is the very common way of trying to change behaviors of people.
Ya, kebanyakan kampanye-kampanye anti narkoba yang dilakukan di berbagai macam negara bersifat menakut-nakuti dengan maksud untuk merubah perilaku, tetapi dengan dasarnya menakut-nakuti.
There's, however, one big problem with those messages. They are not very motivating. They do not generate positive energy toward the change. So this is one thing. The second thing is that all drug users that you're going to see, they already know that. There's nothing new about this. You're not gonna reveal something that they don't know.
Ya, yang jeleknya dari pesan yang seperti ini adalah yang pertama itu tidak memotivasi orang untuk berubah justru. Dan yang kedua adalah semua pecandu itu sudah tahu mengenai masalah itu. Ya, jadi tidak ada gunanya sesungguhnya.
So they come and you will tell them about the gender and they know, yes, I know. And you need to. You say you need to change. They say yes. They will leave. Nothing is going to happen. They're not going to change.
Jadi dengan pesan yang negatif seperti itu, kalau kita bekerja dengan seorang pecandu itu nggak ada gunanya ya. Mereka hanya ngangguk-ngangguk aja, iya, tapi masuk kiri keluar kanan.
So BDRC is rooted in positive psychology.
Yeah.
Positive psychology means we are interested in how we can help people get better. We are not interested in scaring people, telling them what's wrong right now. We are primarily interested in getting to the better state, improving life, rather than fixing bad things that happened in the past.
Jadi konsentrasinya mediasi adalah pada bagaimana kita bisa menolong seseorang, bisa menampilkan hal yang positif dari dia, bukan untuk mengkoreksi hal yang keliru, yang salah dan sebagainya. Dan ini kita sebut sebagai psikologi positif. Jadi hal-hal yang positif dari seseorang itu yang kita tampilkan.
So I'm going to tell you a short story now. The story comes from Africa, from Chad. Another true story.
Saya akan cerita tentang kisah nyata dari Afrika, dari negara Chad. Ya.
So you heard about it. They had a lot of atrocities. There was a war going on, a civil war. A lot of children were killed. You know, they cut off the hands, and there were a lot of brutal things going on. So a lot of people suffer from depression.
Ya, ada banyak orang yang di sana menderita karena masalah depresi ya. Jadi banyak anak-anak juga terbunuh dan sebagainya.
So the Western countries wanted to help, and they provided some funds to send Western psychologists, workers, to help people recover from depression. So they sent a group of well-educated psychologists from England, from Europe, from the United States to Africa to help people recover in Africa from depression.
Karena kondisi depresi yang begitu menyeluruh ya di negara tersebut, banyak pihak-pihak dari negara-negara maju mencoba untuk menolong. Mereka mengumpulkan uang dan kemudian mengirimkan psikolog profesional dari berbagai macam negara ke sana.
And after a few months, one of my colleagues was talking to one of our African colleagues there, and the African colleague told us that they had problems with this Western expert. They had to send them out. They had to kick them out because they were not helping.
Ya, ternyata setelah sekian bulan, orang-orang di Chad itu mengatakan bahwa itu tolong deh, kalau bisa para ahli yang datang dari negara maju itu keluar aja dari negara ini. Mereka benar-benar tidak menolong.
Anyway, to make the story short, he said, why? He tell me what? So for example, they were not taking people out into the sun, which we know helps people recover from depression.
Ya, ternyata para ahli ini tidak membawa orang-orang yang depresi di sana keluar dari rumah untuk terpapar oleh matahari, padahal itu adalah hal yang penting untuk bisa mengatasi.
They were not using drums, music, and dance, which we know helps people to recover from depression.
Ya, si ahli yang dari Barat ini tidak menggunakan peralatan musik ya, atau tidak menggunakan metode tari-tarian dan sebagainya yang kita tahu itu juga membantu untuk kondisi depresi seseorang.
They were not involving families and villages and elders and group and this whole society in the recovery process, which we know helps people recover from depression.
Si ahli ini juga tidak melibatkan keluarga, tidak melibatkan tokoh masyarakat, tidak melibatkan para tetua, sesepuh dan sebagainya di dalam proses pemulihan yang kita tahu itu juga membantu.
They were not doing many other things. The story goes on. But then they said the only thing they were doing, they were locking themselves in small, dingy rooms and talking about bad things that happens in your life, which we know causes the depression.
Apa yang dia lakukan? Sebenarnya dia hanya mengunci diri dia dengan si pasien tadi di suatu ruangan dan berbicara hanya hal-hal yang buruk tentang hal-hal yang dialami oleh si orang tersebut yang membuat orangnya jadi semakin depresi.
Alright? So you see, the story is a good illustration of what I don't want you to do. Your role is not to spend time talking with the patient about bad things that happen in their life and analyzing what and why and tell me more about, you know, getting arrested and having withdrawals and all of this. No, this is not helpful in this regard. We want to take them out of the sun. We want to use music, drums, dancing. We want to use recovery outside of the small room as a vehicle for change.
Jadi tugas kita Bapak Ibu sekalian tidak untuk membicarakan menganalisa hal-hal yang buruk yang pernah dialami, situasi-situasi yang gak enak dan sebagainya, tetapi lebih untuk mencoba untuk memperkuat dia untuk bisa lebih jalan memperbaiki perilakunya.
Let me see. Another important aspect of PDRC that is different than traditional CBT or traditional psychotherapy is that typical understanding of a CBT or psychotherapy or drug counseling is that it's understood as a talk therapy. You heard the term. That counseling or psychotherapy is a talk therapy.
Ya, antara konseling sama psikoterapi adalah suatu terapi bicara ya. Kita harus ngomong lah.
And typically, a course of psychotherapy goes like this. A patient comes to you. You spend 1 hour with a patient or a client talking to them during the counseling session, and then they leave.
Ya, biasanya yang secara klasik adalah orang itu, pasien kita datang kepada kita dalam melakukan psikoterapi selama 1 jam, si pasien bicara dan kemudian setelah selesai dia pergi.
And next time they come, next week they come, they spend another hour. You start where you stop. You continue talking for another hour. The hour ends, they leave again. And it goes on and on and on like this for, let's say, in 6 months or in a month. If you have a once a week therapy, you deliver 4 hours of therapy, 4 hours of counseling, right?
Ya, jadi begitu juga pada pertemuan yang selanjutnya, yang kedua, biasanya kita akan mulai juga bicara dari mulai dari apa yang kita akhiri di pertemuan terakhir dan seterusnya kita lakukan seperti itu. Jadi paling tidak ada 4 jam ya kita habiskan waktu untuk bicara dengan dia kalau itu dalam 1 bulan.
And this is a true talk therapy because everything, the change, the understanding, and etc. happens through talking, through interaction between you and the client or the patient.
Jadi memang yang formal seperti ini betul-betul disebut sebagai terapi bicara karena semua perubahan dan sebagainya merupakan hasil dari interaksi kita, komunikasi kita dengan si klien.
PDRC is not a talk therapy, it's doing therapy.
Nah, PDRC ini bukan terapi bicara tapi terapi melakukan ya. Terapi bukan terapi bicara tapi terapi bertindak. Nah, itu yang paling enak ngomongnya ya. Bahasa Indonesianya bertindak.
So if you learn this, which you've already learning, but you will become experienced, the PDRC goes like this. You meet with the patient for an hour, but during this hour, you're going to work out an assignment for 3 or 4 or 5 hours after the therapy session. Okay, so you talk for an hour, you have an exchange, more than talk. We'll talk about this too, but it's not just talk. And then you send the patient out to his natural environment, where he lives, to his home, with a, let's say, 5-hour assignment to do. And then they come back next session, and you review how this assignment goes. And then you come up with a new assignment or modified assignment, and you send him out for another 5 hours, 8 hours, 1 day, 2 day assignment. And this goes on and on. As you see, in a month of PDRC, a patient gets 20, 30, 40, or 50 hours of therapy. Not just the 4 hours of talking. It gets much more, and the therapy is not done in the counseling room. The therapy is done out there where they live.
Ya, di sini bedanya yang paling jelas dari terapi PDRC adalah dia bukan terapi bicara, dia terapi bertindak. Kita habiskan waktu 1 jam dengan klien kita bicara dengan dia. Tetapi bukan hanya itu, karena apa? Kita akan sama-sama menyepakati adanya tugas yang akan dilakukan oleh yang bersangkutan untuk 5 jam, untuk 6 jam di luar sebelum nanti pertemuan yang berikutnya terjadi. Nah, sehingga ketika dalam 1 bulan kita mungkin hanya ketemu secara tatap muka 2 jam, tetapi secara keseluruhan dia bisa menerima sampai 20 jam terapi karena ada tugas yang harus dilakukan, harus dia tindak lanjuti.
Okay, so you see, that's the difference. The healing process or the recovery does not happen in your counseling group. The bulk of the healing and recovery happens out there where they live, on the street, at home, with his friends, etc. With BDRC, if you're just talking and the patient is not doing anything outside of the therapy session, it's not BDRC. It may be CBT, but it's not BDRC. BDRC only happens when something happens outside of the clinic, of the hospital. How did it become so important? When I was, over the years of my practice, when I was talking to patients in many different settings who went through the courses of different therapeutic approaches, CBT, motivational interviewing, psychodynamic, supportive, and etc., they all told me the hardest thing that they had to do was to apply what they learned with the counselor and get it out on the street. They were fine when they were talking about like drug refusal skills with the counselors and role playing. Everything went fine, and they like it. But when they took out on the street, it rarely worked. This transition from the room, from the hospital, from the counseling room, whatever therapy they were treated with, to the actual environment on the street was so hard that most patients actually failed to apply what they learned into the natural environment. Yeah. So this is the main difference in my mind, and this is how I envision, and that is how I started working. Rather than role-playing and doing what we do, in addition to role-playing and teaching them and training the skills, I tried to apply this concept of guiding them through an actual implementation of those changes, rather than just sending them out and showing them, this is how you should do, go and do. And because most of them will not be able to follow this type of advice. The trick is, how do you make people do what you want them to do?
Nah, soalannya adalah, gimana menurut Bapak Ibu sekalian? Gimana Bu Kris?
Mungkin di dalam ruang konseling, saya ingin apa salah latihan misalnya saya yang menawarkan, ayo dong sama-sama minum dong, bagaimana dia menolaknya, dia supaya terlatih.
How about if you put role play, use a skill in training?
Yes, we do. Yes, absolutely. We do role play. That's what we did yesterday. I invited you to become. This is a kind of. This is how you learn in the clinic. Yes. And role playing plays important role. But role playing here is a protective environment. It's not the real environment. So you tried the patient yesterday under my supervision and in our group. Can you go and do it? Go and do it tomorrow, right? Without deliver what we ask you to do on your own right now. Maybe you do because you are smart and trained and etc. But the patients cannot for them this step of practicing once or twice and then taking it out is difficult.
Ya, jadi betul Bu Kris bahwa memang
traditionally we tell them, even after we role play, you say you should try this what we just learned when you meet your new friend, or when you go back and your friend comes and offers you drug. You should tell them what we just practiced, right? This is the traditional approach. You give them an advice. You practice and you tell them you should. You give them an advice. Do it. Try it. Yes, I should. I know. I will.
Ya, mereka juga jawab ya, nanti akan saya lakukan.
And they leave. And next time they come and you ask them, did you? And what do they say?
No. Itu datang lagi mereka, kita tanya lakukan waktu itu. Apa kira-kira jawaban mereka? Belum, ya.
I did. I wanted to, but I ran out of time, or I had something else to do. There's always a legitimate excuse. Oh, I forgot, or you know, my friend is so smart that it didn't work, or something. I don't know. There's always an excuse. So most of the time, you give them this advice, they don't even try, because the kind, you know, the step is so big. The first step to try is big. And anyway, I see that you know this, so you do have this experience that telling them you should do, you know, cut the amount of use of drugs, or don't talk to your friends, or whatever. They say yes, 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 I know, but then somehow it doesn't happen. Right. Where this contracting come from? We actually discovered this based on research in psychology, in cognitive psychology, that when you actually contract with a person, rather than giving them advice, you develop a detailed behavioral plan. When, what, and how, and you practice this, but you engage them in contract rather than just advice. The likelihood that they will do something, that they engage, grows up very quickly. It doesn't mean that they will do it 100% of time, but your success rate in getting them to do what you want them to do will go from 20 to 60 to 70, maybe 80, maybe even 100% of success rate. Right now, your success rate in applying, in getting them to do what they want them to do is pretty low from what I see. So you need to understand that contract is not a magic pill. It's not a panacea. It's not going to work 100% of the time. There's no a single technique that we're saying that will work 100% of the time.
Ya, jadi tidak ada pil ajaib yang bisa menjamin bahwa semuanya akan berubah dalam 100% ya. Jadi kontrak ini sendiri pun juga bukan berarti akan menjadi 100% ya.
It's important to understand that this is a combination of things that works. That it works sort of incrementally. So if right now you are frustrated, let's put it this way. If you are 100% successful in helping people who stop using drugs, you should leave the room. There's nothing I can teach you. I don't know how low, or maybe it's moderate or whatever. What I'm saying that you can improve your success rate or your performance or your job satisfaction and your effectiveness by 5, by 10, by whatever number. But you definitely improve it. You will see how it goes up when you start applying all this combination of things that you are learning right now. So if you start with confidentiality and privacy, this is going to make you more effective. Patient will like it. If you learn these new communication skills, you will be a little more effective. If you apply a positive emphasis, I'm going to talk about this, rather than negative emphasis, you will get even a little bit higher. If you start using contracting rather than giving advice, you will continue going higher. So, but in combination, it's not a single one of those components that works. It's the whole approach, focusing, respecting the patient, changing the view on addiction, educating them of important aspects, and using these techniques in combination, which is going to make you effective, more and more effective.
Yeah, are there any consequences if the patient
Say again, please.
Okay, on this contract, is there any consequences for the patients if they don't do the?
You mean negative consequences?
Yes, like,
no.
so
No, we don't use.
Punishment.
Okay, let's talk about it, because this is actually important. So again, I'm going to tell you another story or research study. There was a study done in the United States where they wanted to change behavior of women, health-related behavior. Particularly, they wanted them to engage in a cancer screening. So they wanted women. They thought that taking mammography is a good prevention for developing breast cancer for women with certain ages, certain risk. And the researchers were in this health area of health were similarly frustrated, because they were saying people, you should go and do this, and only a small percentage of women actually went to do the mammography. They had excuses why not, and etc. So they did an experiment. They did a study where they enrolled, let's say, 100 or a large number of women, and half of the women they delivered this negatively framed message. They were scaring them. Look, if you don't go, you may develop the cancer, It's very difficult to treat. And then if you die, your children will be orphaned. And you get the picture. It was a message focused on negative aspects of getting the cancer. The second, the other half of women got similar encouragement, but in a positively framed message. Meaning, they emphasized benefits of early detection, that they emphasize that, if the cancer is early detection, it's easier to treat, it prevents long-term consequences, etc. You get the picture. I cannot give you the whole message. But the other message was not scary. It was positively framed, focusing on a positive aspect of prevention and treatment and future recovery if early detection. And again, at the end, they say go and get the screening, go for a mammogram.
Yeah.
Then they look at the rates of people. How many women in each group actually went for the screening? What do you think happened?
Ya, gimana menurut Bapak Ibu? Mana yang kira-kira angka ceknya lebih tinggi, angka tes dirinya lebih tinggi? Yang kelompok pertama atau yang kedua? Positif.
Right. Many more women in the positively framed message group went actually for screening. Many more than in a group that received negative message. So you see, there's a go ahead.
Ya, jadi memang betul bahwa yang kelompok kedua dengan pesan positif yang lebih banyak tes.
So again, this was one of the lessons that negatively or focusing on negative is not energizing. It's informative, it's true, but it doesn't stimulate people to do anything. There's no energy. Versus in a positively framed message, there's an invitation, there's an energy, there's a motivation to do something. And this is simply demonstrated it has been demonstrated many times in various behavioral oriented research. And because this is exactly what we want to do. We don't want to stop anything, the process of change. Therefore, we only focus. We are not the policemen. Remember, the police want them to stop using drugs. We want them to change. We want them to stop, but not by stopping, but by doing something else.
You see it in programs that kick people off methadone if they don't stop using drugs.
Ya. Kita bisa juga lihat bahwa di dalam program metadon ada juga ini masalah negatif, konsekuensi negatif ini atau hukuman ini, seperti misalnya kalau kamu terus pakai narkoba lain selain metadon, kamu harus keluar dari program ini.
Now, we did this in our methadone program for a number of years. If someone continued to use drugs, in spite of a lot of counseling, a lot of effort, we would say, you have 2 months to start giving negative urines or we'll detoxify you and you can't come back for 6 months.
Ya, jadi Joshua punya pengalaman sekali di kliniknya selama beberapa tahun bahwa dengan cara seperti itu, bahwa ini orang sudah mendapatkan konseling dan sebagainya, tapi tetap aja positif ya, sehingga kemudian akhirnya dikeluarkan dalam program.
And I noticed that when that happened, I would oftentimes get telephone calls from patients saying, please let me back on the program because I'm still using drugs and I really want to get back on the program.
Ya, ternyata kalau itu dilakukan juga, Josh sering sekali dapat telepon dari pasien yang tadi dikeluarkan bahwa tolong deh dong, saya diterima lagi dong, karena saya di luar juga masih terus pakai.
Same thing. So then we looked at death rates. In the U.S. we have a death index. It's a national death index that records deaths and the cause of death. And we took the names of the people who had left the program and we looked at the death index to see if they appeared.
Ya, kemudian ada di Amerika kan bagus ya, ada indeks kematian yang memang sangat tercatat dengan baik dan rapi ya. Nah, kemudian Josh mengambil daftar orang-orang yang dikeluarkan dari program dan kemudian dicocokkan dengan indeks kematian yang dikeluarkan secara nasional tadi.
And we found that when we compared the people who left with the people who were on the program, we only had one drug-related death in the program. We had like 5 or 6, just within a year of the people who had left the program.
Ya, ternyata setelah dilihat, ya dibandingkan, kan itu ada daftar namanya ya, indeks kematian itu. Setelah dibandingkan adalah orang yang masih bertahan dalam program, yang kemudian mati terkait dengan persoalan narkoba, itu hanya 1. Sementara orang yang meninggalkan program, itu sampai 5-6 kasus. Jadi 5 kali lebih banyak daripada kalau dia bertahan di dalam program.
Yeah, and some of those deaths were overdoses, some were medically related, but they were significantly more in the people who had left the programs compared to the people who were, there was hardly any of the people from overdoses, the people who stayed with the program.
Jadi kalau orang tuh kita keluarkan ya, keluar dari program dan sebagainya, itu kematiannya bisa karena overdosis, bisa karena masalah-masalah medis lainnya, tapi yang jelas adalah berkali-kali lipat lebih tinggi daripada kalau dia bertahan di dalam program.
Now the other side of the coin is that if you don't make those threats, you will have more positive urines in the program because the threats do help some people to stop using. So they do work. But they have this side effect that's very bad.
Ya, jadi ini seperti dua mata uang ya. Jadi di satu sisi tadi seperti itu, kalau dikeluarkan dan sebagainya kita kencang dia bisa meninggal. Di sisi yang lain, itu sebenarnya yang namanya tes urin untuk mengecek positif atau enggak dan kemudian diancam untuk keluar, itu adalah hal yang bisa bekerja untuk menghentikan orang menggunakan narkoba.
So I do agree and disagree with you.
Let me say, so if you have a new drug in the U.S. and you want to get it approved, you have to prove it's safe and effective. That procedure is effective for it'll help some people stop, but it's not safe. Personally, I don't feel comfortable doing it. No, some people feel more comfortable. I don't feel comfortable because of that negative.
Safe and
Effective. Personally, I don't. It does work. It's effective, but it is not safe because it's associated with higher death rate.
Di Amerika itu untuk bisa sebuah obat baru itu diterima itu harus dia efektif. Yang kedua adalah juga harus aman. Nah ini sama saja seperti itu. Kalau kita membuat tes urin untuk membuat suatu ancaman dia harus keluar ya, nah itu memang efektif, bisa menghentikan orang pakai, tetapi tidak aman. Karena kemudian angka kematiannya kalau dia di luar dari program, artinya ancaman dikeluarkan itu tadi seperti tadi obat ya.
So then, what do you do with these patients? And the best thing I can think of is just be patient and be persistent. Because if you are persistent, over time, a lot of them will get better. They don't always get better as soon as you would like them to. Sometimes it takes a lot longer. But if you follow them over time, and people have done this, there is a good proportion of them that will get better just by being patient.
Ya, Jos itu kalau secara pribadi merasa tidak nyaman melakukan itu ya, harus mengancam dia untuk keluar. Jadi apa dong yang harus kita lakukan? Yang pertama adalah sabar. Yang kedua persisten. Persisten itu artinya kita harus konsisten, tetapi juga tekun, ikuti dia. Karena ada beberapa pasien yang memang membutuhkan waktu lebih lama untuk dia berubah perilaku.
Those patients are very demoralizing because you try your best and they don't seem to get any better.
Yeah.
And sometimes you get angry at the patient.
Ya, memang pasien-pasien yang seperti ini benar-benar menurunkan moral kerja kita ya. Kita merasa, aduh, udah berbuat yang terbaik kok orangnya itu kurang ajar ya. Ya, jadi kita bete ya.
And then you say, get out of here.
Stop it. I have to intervene because I am in a different school. That's tough. I hope the judge is not recommending this. Get angry, kick them out.
No, I'm not. No, I'm saying don't do it. I'm saying be patient, persistent, and do your best.
So
It's actual here.
huh?
I mean, it's actual. Yes. It's here.
Okay. So the contingencies, even in George's story, the moral is that contingencies work when you apply them, but when you remove them, they don't stop working. There's no long-term consequences of the contingencies. This is what this is, and there's a lot of research showing exactly that. That for example, there's research in contingency management. Yes, as long as you're paying them, as long as you're scaring them, whatever it works. The moment you stop, it doesn't work anymore. There's no long-term consequences. This is the problem with contingencies.
Ya, ini yang disebut sebenarnya adalah manajemen kontingensi. Jadi kayak manajemen diberikan upah seperti Bapak Ibu menjanjikan akan memberikan suatu hadiah kalau anak itu nilainya bagus. Kalau Bapak Ibu kasih terus, ya itu akan berhasil. Tapi kalau Bapak Ibu berhenti, udah nggak ada jalan. Jadi nggak ada perubahan perilaku kan, gitu.
So this is the main reason why we do not use any contingencies in the EDRC treatment. We do not use this contingent, you know, if you do this, you get rewarded, if you do this, you get punished. No, we don't do this.
Ya, jadi dalam mediasi kita nggak perlu menggunakan sistem hadiah seperti itu, nggak ada ya. Jadi kalau dia melakukan sesuatu kita kasih gitu enggak ya.
Yeah, George is right. Let's talk a little bit about this frustration. You know that you eventually get. So how? Again, we need to learn how to handle this. I think I have some suggestions.
Jadi apa yang tadi dikatakan George itu tepat sekali buat kita ya. Jadi nanti Marek akan bicarakan bagaimana kita mengatasi rasa frustasi kita dalam menghadapi pasien-pasien ya.
So let's start again. This may be a little puzzling for you, maybe not. That I'm telling you, focus on positive, make a positive frame, but then tell the patients that they are sick. The starting point of BDRC is we're supposed to educate them that they have a disease, that they have a brain disease. Some people will may look at this is not positive. How good is it? It is not positive. For patients, for opioid-dependent individuals, this is a happy message. If you tell them that they are patient, that they are sick, they will be happy. It will make them happy.
Ironisnya, kalau kita bilang bahwa mereka adalah orang yang kenyataannya mereka justru senang.
Why? Why do you think so?
They said no, they don't feel happy.
Then another story. All right, there it goes. So I'm sure I can convince you. We'll talk. There is somebody coming, I think. So we'll see this in action. I can guarantee that we'll see it in action. If you ask opioid-dependent individual, or heroin user, or drug user, what do they think about themselves? They say that they are ashamed. They feel guilt. They feel that they are bad people. They are rejected by the family, by the society, and etc. They are at the bottom of the social class, right?
Ya, jadi Bapak Ibu kan tadi bilang
on the first visit, they kind of sit like this, and they look depressed and down. They are not very engaging. They are kind of sad, and they I ask them, you know, so tell me your story. Why are you here? Oh, I've been trying to not use drugs for a long time, but I think I won't be able to stop. It's so hard. I don't know what to do. I must be a bad person. Or I'm very weak. I know other people are stronger, etc. You hear the stories over and over. They are really, really down and not very happy about it, right? On the first time when you see them.
Ya, pertama Marek, kalau ini nggak tahu gimana Bapak Ibu ya. Kalau pertama kali biasanya ketemu sama seorang terapis, biasanya mereka tuh menatap mata kita pun juga agak segan ya. Kebanyakan dia mengatakan saya tidak tahu harus mulai dari mana, saya melakukan suatu hal dan sebagainya.
They are not proud of themselves.
Mereka tidak bangga ya sama dirinya sendiri. Mereka tidak bahagia.
There's a lot of shame and guilt and etc. associated, rejection.
Ya,
I don't have any friends, my family doesn't talk to me, etc. You heard this, I'm sure you did.
Termarginalisasi oleh keluarga, bahkan sama masyarakat, sama ya.
And then I asked them a question, why do you think this is so hard? Why do you think you continue using drugs despite your efforts? And they usually will say, I don't know. It must be me. I'm somehow, you know, not a good person. Other people can do it, but I cannot do this.
Nah, biasanya kemudian Marek akan tanya, menurut kamu kenapa kamu sampai susah sekali berhenti ya? Kamu balik lagi. Biasanya mereka akan nanya, ya saya nggak tahu, ya mungkin karena memang saya nggak benar, saya memang jelek dan sebagainya, motivasi saya kurang kayak kemarin dulu ya.
And then I start educating them, and I tell them, look, let me tell you something. I think that, and I slowly explain to them the problem with drugs, how they affect the brain, and etc. I'm going to practice this, and I tell them, I try to convince them that what they have is a medical chronic condition that is similar to diabetes, hypertension, asthma, and it can be treated in a similar way. And okay, go ahead.
Ya, biasanya kemudian mereka mencoba menerangkan kepada mereka, memberikan edukasi bahwa ini adalah chronic relapsing disorder, seperti halnya diabetes, hipertensi, sama asma, dan kita akan bisa itu diatasi dengan cara yang kurang lebih sama seperti kita mengatasi diabetes dan kawan-kawannya.
And if I'm good at what I'm doing, they start sitting like that. And then I start building the argument about them being diabetes, and they start paying attention, they start listening, because something new. And then they smile. At the end, when I tell them, when I'm very convincing, and I convince them that they are like patients with diabetes, they say, wow, this is great, can you tell this to my wife?
Ya, jadi pada awalnya pasien datang dengan nunduk ya. Kemudian ketika Marek sudah mulai menjelaskan dan pasien mulai merasa bukan meyakinkan, bukan nyaman, tetapi merasa oh ada sesuatu yang lain ya, dan dia akan mulai naik ke kepalanya, kemudian dia akan lihat benar tuh begitu gitu ya. Jadi dia akan merasa bahwa ini sesuatu hal yang baru buat dia, dan dia biasanya akan minta supaya kita ngomong kepada keluarganya, kepada istrinya.
Yes, it happened to me many times. That I had this revelation. This is great. This is great news. I'm just a sick person. Can you tell it to my wife? Can you tell it to my mother, or something like this? I had this experience multiple times.
Ya, jadi mereka punya berbagai macam.
It's elevation. This is not like a bad news. Like you tell the patient who has a heart disease, they may get scared or may cry or something like this. It's a bad news. No, telling a patient who a diagnosis of diabetes is a bad news. Telling the drug users that they have a disease like diabetes is good news. It's a good starting point.
Ya, jadi pasien itu senang kalau diperlakukan sebagai pasien. Jadi kalau kita bilang bahwa ini adalah penyakit, ini beda sama kalau orang didiagnosa hipertensi atau diabetes. Kebalikannya justru kalau dia dibilang dia adalah penyakit kronis kambuhan, terus jadi senang, dia malah lebih optimis.
That was an excuse for him to use it again and to
No,
tell the mother.
It's not an excuse.
That I need that drugs. Is that an excuse for that?
Well, that's the they say if a medicine doesn't have some side effects, it doesn't work. And I would see that as like a potential side effect, which you can deal with. Because you can say, well, you have a disease, but you have some responsibility to take care of it, and you can do it. So put it in that way, and that will help to.
Yeah.
Yeah.
Ibu Kiki tanya tadi, nanti kalau kita bilang bahwa dia menderita penyakit, bisa nanti jadi alasan buat dia untuk ya udah emang saya harus pakai lagi gitu ya. Nah, Josh bilang itu bukan kesana larinya, itu memang ada side effect-nya, merupakan suatu efek samping dari kalau kita ngomongin sebagai penyakit. Tapi selain itu adalah penyakit, kita juga perlu mengedukasi dia bahwa dia perlu bertanggung jawab atas penyakit tersebut.
It's not an excuse because nobody wants to have a disease. A patient with diabetes doesn't want to be in diabetes. It's not a motivational factor. It's not an excuse. A person who has asthma does not want to have asthma.
But they're happy while using it. But diabetes doesn't happy after they use the drug.
Who's happy?
The junkie use it. Drug is they get high.
Junkie. Marek mengatakan bahwa ini tidak akan menjadi alasan buat mereka untuk digunakan sebagai pembenaran untuk pakai lagi, bukan. Karena tidak ada seorang pun yang ingin menderita penyakit ini. Tidak ada orang yang ingin bercita-cita menjadi seorang penderita diabetes dan hipertensi, dan tidak ada seorang pun yang ingin menjadi seorang pecandu. Tapi Ibu Kiki berdebat dalam hal ini mengatakan enggak, itu nanti bisa menjadikan alasan. Tolong ini dalam positif, psikologi positif ya.
Okay, let's talk about it. You made a very interesting statement. She said these junkies are happy.
Yeah.
Let's discuss it for a moment.
Ya, kita akan coba bahas ya, kan tadi Kiki bilang bahwa seorang junkie itu, pecandu itu adalah orang yang bahagia.
After they using it, the impact is they get high and different like diabetes.
Anybody wants to discuss
Ada
it?
yang mau komentar, karena seperti Ibu Kiki tadi bilang bahwa setiap kali habis pakai kan dalam waktu singkat dia akan merasa pedau ya, merasa enak gitu ya. Ada nggak yang mau itu? Jadi itu membuktikan bahwa dia itu sebenarnya bahagia. Silakan berkomentar Bapak Ibu sekalian.
You can challenge that belief. You can say, you say you're happy. I mean, you really think you're happy? How can you tell me you're happy? Okay, you feel good for 20 minutes, but
Ya, dia capek dengan keadaan itu. Dia kan berbeda dengan orang yang lain. Kenapa dia berbeda dengan orang lain?
So yes, very good. So who saw a happy junkie? I want to see a hand.
Siapa yang melihat?
Who actually saw in your practice, in your office, a happy junkie? Somebody who said, "I'm happy. I want to do it. I continue to do it."
Di tempat praktek bahwa pecandu itu bahagia.
How many? I want an example. Tell me a story about a happy junkie.
Saya punya pengalaman memang kalau beberapa klien saya itu kalau dia tidak bahagia dalam dia sebagai pelarian menggunakan dia dia pengen keluar. Kalau dari bilang sakit betul dia menurut saya kalau mau enggak saya butuh obatnya. Jadi kalaupun dia gembira, kalaupun dia merasa ramah baik itu kamu rasa bukan karena dirinya sendiri. Kayaknya kecil dia harus berdiri sama.
So you see, you had a good point, very good point, discussion point. You remember the pictures yesterday that I showed you? No, the pictures of a person, the real person. My question, is he happy?
No, for 10 minutes, they feel, for 10 minutes they feel euphoria after using. For 10 minutes. And we can see the dragons, we can see the glamour of it.
Okay, so what do you think is euphoria? What do you think is euphoria for this guy? What does it mean?
Marek tanya ya, jadi apa yang bisa diambil dari diskusi ini, karena Ibu Kiki membuat suatu topik diskusi yang menarik ya. Coba kita ingat yang kemarin, gambarnya orang Iran yang kemarin, menurut Ibu Kiki 10 menit dia euforia dan itu. Nah sekarang Marek tanya, apa sih yang dirasakan dengan euforia itu? Apa sih sebenarnya?
What is euphoria for this guy? What do you think it is?
In the brain, just for 10 minutes.
Say again?
You feel the euphoria in the brain for only 10 minutes.
No, but what does he feel for 10 minutes? What do you think he feels for 10 minutes?
Apa sih euforia itu ya? Selama 10 menit itu dia ngerasain apa kira-kira?
I don't know, comfort.
What else? Tell more. What do you think it is euphoria for this person?
Kalau
For most of the
apa yang dirasakan? Tenang,
What you're describing is not is describing of what you experience. We experience normally many times a day. Calm, comfort. Are you comfortable now? Do you have any pain? Right. Is it euphoria for you? No, exactly. You see, I caught you. This is exactly the point. What you describe, euphoria, the word euphoria implies happiness, paradise, flying high, or whatever. No. This is not what this guy experiences. This is not what this guy experiences in the bathroom of a public restaurant.
Jadi tadi dari diskusinya kita tahu bahwa kemarin betul-betul bertanya apa sih sebenarnya euforia kan? Dan kita menjawab itu kalem, tenang dan sebagainya. Apakah kita juga merasakan hal yang sama? Kita juga kalem kan? Kita tenang kan? Itu juga bahagia kan? Nah kira-kira itu euforia itu seperti itu saja, bukan sesuatu hal yang seperti ada di, bukan seperti pemahaman kita bahwa yang euforia itu berada di surga, di awan dan sebagainya.
So this is what people think is happiness, but there is no such thing. It's a misconception, misunderstanding. There is no such thing like a happy junkie. No, doesn't exist.
Ya, jadi yang namanya ini ada pemahaman yang sangat keliru ya. Mungkin junkie juga mengalami pemahaman yang keliru gitu loh. Bahwa euforia itu tidak ada yang istilahnya euforia sama dengan di surga dan sebagainya.
Even if there is such person exists, you are not going to ever see this person. A person who is a happy junkie is not going to come to the clinic and help me.
Ya, biasanya seorang yang dia bahagia menjadi seorang pecandu tidak akan pernah datang ke klinik, tidak akan datang ke klinik dan meminta pertolongan kita.
Right? No, you're not going to ever see a person who is a happy junkie who says, I'm very euphoric, but I wanna stop this happiness from occurring to me ever so often, so just help me. No. The opiate-dependent individual feels that the way they describe it to me, it's a burden. I don't want it. Help me. I have a monkey on my back. I'm not in control of what's going on with me. I don't want to do it. I cannot stop. It's not in my will. You see, this is the difference. Sorry, go ahead.
Jadi, seorang pecandu yang katanya happy tadi jelas tidak akan minta pertolongan kita dan mengatakan pada kita bahwa tolong deh saya minta dibantu supaya untuk mengurangi kebahagiaan saya, nggak akan. Jadi yang datang pada kita ya adalah pecandu yang tidak bahagia. Sebab apa? Dia membawa beban seperti menggendong monyet di belakang hukumnya ya.
This is the common, what we are discussing is very good. It's a common misconception that if only somebody was strong enough or had enough strong motivation, etc., they will stop using drugs.
Ya, jadi ini bagus, bahan diskusi yang bagus. Jadi nggak apa-apa, lebih baik kita begini, karena kita tahu bahwa ternyata memang di antara kita sendiri juga masih ada konsep atau pandangan-pandangan yang keliru. Karena tadi apa lupa jadi. Oh ya, I'm sorry. What is the last statement? That is important.
That only, people. There's a general misconception that if you're strong, if you know that you can build a strength and you can stop using drugs by sheer will, by motivation, by something, being a better person, not becoming a junkie, and etc. I have a story to tell. I have to tell another story.
Kalau memang itu hanya perkara masalah kemauan, seharusnya berarti sebenarnya hanya dengan meningkatkan motivasi dengan kuat saja orang bisa berhenti. Nah ini kan enggak sesungguhnya. Ada banyak hal di otak kita.
Alright, another story, real story from China. 3 years ago, I'm doing the training like this in China, and I'm talking to people in China, and they tell me a story about one patient and his wife.
Jadi cerita nyata di Cina 3 tahun yang lalu waktu Marek mengadakan training seperti ini tentang seseorang dengan istrinya.
So somewhere in central China there was a couple, husband and wife, and the wife, they were happy, but the husband they were happy with marriage, sort of. The wife loved the husband, but he was a drug user. He tried, he couldn't stop using drugs. He was opiate dependent, using heroin, no matter how hard he tried. He was a junkie.
Ya, jadi mereka suami istri ini punya kehidupan perkawinan yang bahagia, tetapi si suami ini adalah seorang pecandu ya, yang sering kali gagal dalam persoalan pemulihannya.
And his wife wanted him very much to recover. She wanted to help him, and she thought about herself that she's smart and strong person, stronger than he, because she was carrying the responsibility and etc. And she came up with a good idea.
Ya, jadi si istri ini pengen banget si suaminya itu berhenti ya, dan dia si istri menganggap dirinya sendiri sebagai orang yang lebih kuat dari suaminya karena hampir semua urusan rumah tangga dia yang urus, dan dia punya suatu ide ya, suatu gagasan yang bagus menurut dia.
She came up with the following plan. The plan was that she will start using heroin. She will start using heroin in order to learn what does it mean to be a junkie.
Ya, jadi si istri ini kisah nyata ya, si istri mikir, bagaimana kalau kepada Marek dia tanya, bagaimana kalau saya mulai saja pakai heroin? Ya, jadi saya bisa memahami betul bagaimana susahnya.
Yeah, she will learn firsthand. She will have firsthand experiences of what her husband experiences, and because she's smart and she's strong, she will also learn how to stop. She will develop a way how to not use drugs. And then she will be able to help the husband.
Gagasannya adalah dia akan coba heroin, dan karena dia orangnya pintar.
She put the plan in motion. She started using drugs. She used it for several weeks. What do you think happened?
Ya, apa yang dia akan belajar sesuatu? Waktu itu dia belajar sesuatu nggak? Iya. Keep using.
Yes. Yeah. She was not able to stop. We had one. So initially we had a family with one drug user, and then because of this smart plan, we now had a family of 2 drug users who could not stop using drugs.
Jadi setelah beberapa minggu ide yang cemerlang tadi, dia sama sekali tidak bisa berhenti. Jadi yang tadinya datang cuma 1, sekarang menjadi 2 orang. Ya. Makanya karena rencana yang begitu cemerlang tadi.
Why she was not able to stop using drugs? She was smart and strong.
Ya, kenapa kira-kira nggak bisa berhenti? Padahal dia kan
She was not a junkie. She just did it to help his husband, her husband.
Kenapa kira-kira nggak bisa berhenti? Karena dia pintar, dia kuat. Ya, itu dia. Addiction.
Yeah, she developed a disease of opiate dependence. She was unable to stop. So you see, now this is my question: how people become dependent? How do people become opiate dependent?
Gimana sih orang?
In your opinion?
Neuroadaptation.
No, but in life, I mean, what life circumstances begin people, make people start using drugs or continue using drugs? How people get into drug use or heroin use?
Situasi lingkungan seperti bagaimana sih yang membuat seseorang itu menjadi seorang pecandu?
What stories do you hear from your patients?
Apa yang kita dengar dari pasien kita?
Yes. What else? We know broken home environment, friends, but what else?
Apalagi teman, unhappy.
All right, I get the picture. So, which social class occupy? I mean, what members of what social class are most heroin users?
Ada kelompok sosial ekonomi yang bagaimana yang biasanya heroin itu banyak terjadi, ketergantungan heroin.
Yeah. Have you seen students using drugs?
Ada nggak mahasiswa di sini?
University students. Professors, university professors. I have. Doctors. What about medical doctors?
Ada nggak dokter yang
Have you seen medical doctors? Yes, you've seen. What about nurses? Yes, I have. What about
psychologists?
What about airline pilots?
Oh, pilot.
Why?
Apa kira-kira?
Karena dia tidak pernah lingkungan ya.
Exactly. What about wives and women who are good women?
Ya perempuan baik-baik kan nggak yang jadi pecandu?
Right. So you see, we cannot apply. There is no concept of junkie. We do not use this concept of junkie. Sorry, we do not, because I tell you that if I use heroin for 5 days, if somebody injects me with morphine for 5 days, or another important group of people who who have accident, undergo operation, and they get morphine anesthetic for extended period of time. Many of them, or few of them, or some of them, I don't know the exact number, but some of them develop opiate dependence.
Ya, jadi Marek tuh dan kawan-kawan tidak lagi menggunakan istilah junkie. Ya. Karena itu bisa terjadi pada siapapun. Bahkan seseorang pasien yang bukan seorang siapa-siapa, tapi dia karena kecelakaannya harus menjalani operasi dan mendapatkan suntikan morfin, hanya dalam 5 hari saja bisa mengembangkan suatu adiksi. Ya.
So, becoming opiate dependent is not a choice.
Ya, jadi orang yang menjadi seorang pecandu opiat itu bukan suatu pilihan sesungguhnya.
If I use for whatever reason, somebody forces me to use heroin for 6 days, for 10 days, to be injecting me constantly heroin for 6 days, and on the 7th day they don't give me injections, I will be begging them, please give me more.
Ya, jadi Marek sendiri akan bilang bahwa dia menjamin kalau dia dapat suntikan heroin ya dalam selama 6 hari berturut-turut, hari ke-7 dia pasti akan minta, mengemis-ngemis untuk minta disuntikan.
And it will happen to all of you. Any one of us is equally vulnerable to become opiate dependent.
Seluruh dari kita itu sangat rentan untuk menjadi seorang ketergantungan opiat.
So at the time of initiation, when you try, whether you have a decision whether you're gonna try first time or not, should I try it or not? Even after a few weeks of using, should I stop it or not? You still have a choice. It is a choice, right? You have a choice, you have a moral duty or whatever it is in the initial stages. After 5 years of using street heroin, it's not a choice. It's not a matter of your strong will.
Jadi pesan yang sangat kuat di sini adalah pada saat awal dia mencoba, di situ memang masuk ada masalah-masalah moral kita. Apakah kita akan berhenti, nyoba atau enggak? Itu pada awalnya saja. Begitu dia sudah 5 tahun, 1 tahun, 5 tahun, 10 tahun ketergantungan, sudah lagi bukan persoalan moral. Karena siapapun dari kita, sekuat apapun iman kita, kalau sudah kuat, sudah lama begini, itu tidak ada lagi pilihan. Dia harus pakai.
Okay, so no, we do not use the concept of junkie or happy junkie or any other junkie. This is what we try to change. And I don't agree with you. You raised a very important point. Thank you for bringing it up. That you said that this may be used as an excuse. But I have never seen it once in my life, in my practice, that somebody said, oh, because I'm sick, I will continue using this. I will continue doing this. Never happened to me. I want to hear a counter otherwise. If you do hear something like this, let me know. But so far, in my 15 years of practice, it never happened to me once. I keep pounding it because you will not become effective in what you do unless you truly believe that these people are patient. This is the critical starting point. I will take as much time as it takes. I will take as many questions as it takes to try to convince you, to try to educate you, to try to show you that this is a good way of starting process of recovery. If you are able to convince yourself first, and then your patient, that he is a patient, he or she is a patient, not a junkie, a patient, like diabetes, asthma, hypertension, you have a much easier way to go.
Yeah.
Just to make a couple additional points, Marek mentioned this, that I don't know if there's a happy junkie. There might be some running around the street, but the people that come to treatment are not happy because they're having trouble. So you're seeing a selected group of the overall population, and they're generally not too happy for a variety of reasons. But that's one thing. So, and then another is that there are some studies showing that if a person self-administers a drug as compared to get it for pain after surgery, if you get it for pain after surgery, you have a serious operation, you take it, you'll get withdrawal, but that isn't really addictive because you don't necessarily develop that drug-seeking behavior.
Ya, jadi tadi Josh menambahkan apa yang tadi sudah dikatakan Marek, bahwa mungkin saja ada seorang pecandu yang bahagia, tapi dia berada di luar biasanya. Jadi yang kita temui adalah orang-orang yang datang ke klinik kita adalah orang-orang yang betul-betul membutuhkan pertolongan dan mereka tidak happy. Nah, yang kedua mengenai orang yang dia kecanduan karena dia pakai sendiri, itu adalah orang-orang yang memang kecanduan karena dia mencari barang bagi dirinya sendiri. Sementara orang yang karena operasi dia disuntikan morfin yang kemudian jadi ketergantungan, itu dia tidak mencari barangnya.
So people are becoming addicted, but the risk is really high if someone is self-administering it to themselves rather than getting it on a prescription from a doctor. That's where the risk really goes up. And that's basically pretty much what you're seeing here. I think you're seeing people who buy on the street decide they're going to experiment like that. The third point is that there are genetic determinants to addiction as well. There's a lot of literature coming out that some people are more susceptible to it under either of those conditions, whether they're given it for pain control or self-administering. Like if you have a strong family history of any kind of addiction, you're much at higher risk to develop alcoholism or opiate dependence or whatever if you dispose it anyway.
Yeah, which actually proves that it's a supporting point that this is a disease.
It's a disease. Exactly.
Yeah, right. Because it has a genetic component.
The genetic studies have been some of the strongest evidence that have convinced politicians, the general public, that we're really dealing with a disease and not just bad behavior.
Ya, jadi yang ketiga yang juga penting sekali Bapak Ibu ketahui adalah ternyata dari hasil berbagai macam penelitian apalagi yang terkini mengenai masalah pokoknya itulah ya, diketahui bahwa ada komponen genetik yang diturunkan kalau yang membuat orang menjadi lebih rentan terhadap masalah adiksi, baik itu dia adiksi kepada resep yang dokter karena kronik pain-nya atau dia adiksi untuk pakai sendiri, dan ini membuktikan bahwa ini adalah sebuah penyakit.
We also face a situation where in one family there is one more drug user.
Yes.
So are you saying that it is because of the genetic one, not because of their copying the behavior?
Well, that's it. What I'm saying is that the genetics are a major risk factor. Environment is another risk factor. High levels of psychiatric symptoms are another risk factor. Peer pressure, another risk. There are a number of risk factors. Genetics is a strong risk factor.
Ya, jadi memang betul bahwa tadi Ibu Christine nanya.
It's hard to determine because if you have siblings or people in the same family, they typically, especially here, they will also live in the same environment. They have some external influences, so it's really hard to tell which comes first. but it's a combination of factors and genetics from studies, from twin studies, from studies employing people who are genetically similar but live in a different environment. Scientists were actually able to determine the role of genes, and it's clearly there. Even if you remove the influences of environmental influences, people who have very similar genetic inheritance and living in different environments, a higher proportion of them develop drug dependence than people who have different genetic makeup.
Ya, jadi kalau tadi yang kasus saya itu tidak bisa menentukan mana faktor risiko yang paling dominan. Kenapa? Karena adik kakak ini tinggal di satu rumah yang sama. Jadi kita nggak bisa lihat mana yang paling dominan karena banyak multifaktor. Tetapi kalau di Amerika Serikat itu penelitiannya adalah meneliti dua kembar, orang kembar jadi dengan secara genetik sama, tapi dipisahkan dalam lingkungan yang berbeda. Dan ternyata terlihat bahwa dua-duanya tetap pakai. Jadi walaupun lingkungannya berbeda, nah ini yang menegaskan bahwa ada faktor genetik yang berperan.
But it's not dissimilar from a lot of other diseases where if you have diabetes, it's a disease. The doctor can do something for you, prescribe medicine, but you have to take the medicine. You have to, there's a role for your own involvement in your own recovery, and that's a mixture is very, very important. Combination of factors that help people recover.
Ya, jadi kombinasi
Oke. Ada perawat pakai 3 kali sampai 3 kali dia mabok lagi temennya, mabok lagi 3 hari berturut-turut. Coba lagi besok pakai barang lagi gitu ya, karena sekamar. Tapi saya nggak apa-apa, dia mabok lagi kayak enak bener. 3 hari akhirnya dia ini kok cocok buat saya.
You see, yes, very good. Yes, you see that another misconception. Many people, you may think, or many people think that the first experience with heroin is euphoria, it's happiness. For many people, it's not. It's just like you. I heard many times. They vomit, right? A lot of people feel nausea, feel really uncomfortable. They actually need to learn to experience this pleasure. They need to learn what to do with heroin. They are introduced, they never use it on their own. There are friends who tell them, no, this is why it didn't work. You have to do this in order to get that. It takes time.
Ya.
It's not, so anyway, go ahead.
Ya, jadi Bapak Ibu, nah ini ya kita nggak pernah nanya, jadi nggak pernah mikirnya, kita berpikir bahwa sekali pakai langsung happy, tidak ya, jadi selalu seperti itu, selalu butuh waktu bagi seseorang untuk bisa merasakan nyaman ya.
So to some extent the learning theory is wrong, because the learning theory, the old theory says that you try something, you experience pleasure, and you get a strong association of happiness with using drugs, you continue doing this. But based on this theory, for these people who the first experience is unpleasant, they should stop. They don't. It goes like this. Initial experience is not pleasant. Then after they learn, for a short period of time, they experience pleasure. For, weeks, maybe months, maybe a year. But then it rapidly goes down. And then from then on, they only use drugs to feel normal, to be able to get up in the morning and not vomit, to be able to get up and get going, not feel pain, feel some little bit of relief from the problems. And this goes on for years and years and years.
Ya, semua orang yang mencoba ini heroin pertama kali tidak ada yang merasa senang.
Also, probably talked to other people who said they felt they were addicted the first time they injected it. It feels so good that they knew they were addicted. I, in my own mind, wonder if those are people with a particularly high genetic susceptibility. Just seems like their nervous system is wired differently than the majority.
Ya, nah ini Bapak Ibu sekalian, ini ada juga informasi yang penting bahwa mungkin saja pasien kita ada 1-2 orang yang mengatakan bahwa saya sekali 2 kali pakai itu langsung merasakan ketergantungan. Nah mungkin ini faktor genetik yang secara neurologis dia berbeda. Nah ini jangan sampai terjebak.
But however, whatever their first experiences were, by the time you see them, they've got this, this syndrome, you know, is described as addiction.
All right, so let me ask you the following question. Do you like working with your patients? Do you like them?
Bapak Ibu senang nggak sih kerja sama
Do you like your
pasiennya Bapak Ibu nih yang namanya pecandu heroin ini? Ayo.
Do you like your junkies?
Ya, more or less.
Awalnya enggak, tapi ya
In the beginning, I didn't like them, but now it's getting acceptance. It's already, I'm already there, so I cannot refuse.
So you're just doing your duty, you know, you don't like them, you don't dislike them, you just go with the motion.
Ya, jadi hanya kerja begitu aja lah. Kalau ngomongnya nggak pakai emosi lah. Sebab saya sebenarnya kepaksa kerja di sini. Ya.
Alright, other people.
Yang lainnya ibu yang pernah bicara ibu Risma, pernah tadi ya. Ya barangkali ada yang lain. Suka nggak kerja sama mereka?
Awalnya emang ada hambatan.
Itu sih yang harus ini.
Ada rasa timbul kasihan.
Now I feel
Okay. Anybody else wants to share? Do you like them? You don't like them? Why do you like them? Why you don't
Pak
like them?
Anur, jadi suka nggak? First I feel great, now I like them very much. Oh, it's very challenging. Very challenging.
Okay.
At the beginning it was very hard, but because probably I only have limited knowledge. Sometimes I felt negative. Yeah.
Frustrated. Alright. Anybody else want to say something? What do you dislike most? Let me ask you. Go ahead. What did you say? So it looks like, I'm hearing again, I took a quick poll. It looks like most of you like working, but you see the challenge. You said that it's either was difficult or is difficult, it's challenging, and etc. Which part is most difficult or annoying, or which part you don't like?
Yang mana sih yang paling berat ya? Memang ini suatu
What
hal
do
yang
you don't
menantang ya.
like about your junkies?
Apa yang paling tidak disukai dengan kerja dengan seorang pecandu?
If you cannot change their behavior, why are you staying with
No matter what you do, they don't change. That's what he's saying. All right. Anything else?
Kalau dia if they lie to us.
Okay. Anybody else want to say on this?
Manipulative behavior. They're manipulative behavior.
What?
Manipulative.
Manipulated. Why do I know things?
Dirty words.
So yes. So what do you? I actually, before I listened to it, I put something on the slide. Actually, so you told me things like they lie, right? Somebody, yes, they lie. They are manipulated. They don't change. They don't collaborate. They don't cooperate, right? This is the frustration. So yes, I agree with you, sir. And I put this thing here that they do. Why they are like this? Why do they lie? Why do they manipulate? Why this is frustrating? What do you think is the source of that? Yeah, but where does this typical behavior is different between drug users and other patients?
Jadi Marek punya pendapat yang berbeda dari kita. Kenapa mereka seperti itu? Jadi sama-sama kronik seperti chronic disease seperti diabetes, tapi ada satu hal yang membedakan dia dengan yang kronik lainnya.
Drug users are very good at making you feel guilty, and manipulating you, and evoking certain things, and making sure that you do what they want you to do.
Ya, jadi seorang drug user itu paling senang memanipulasi kita, membuat kita merasa bersalah dan melakukan sesuatu hal yang sesuai dengan yang dia inginkan.
It is not true for the patients who have diabetes. Patients who suffer from diabetes do not have this particular skill. They are like any other person. They don't do that.
Ya,
they don't know how to do that.
Kalau penyakit diabetes, penderitanya nggak pintar membuat kayak gitu. Tapi kalau seorang drug user terlatih.
They are bad people. They simply have much more experience in doing this. All right. So this skill of manipulating, the skill of making story, the skill of getting you to do what they want to do, not what you want to do, comes from years and years of experience.
Nah, jadi ini bukan persoalan kepribadian sesungguhnya, bukan seseorang yang kebiasaan mereka yang seperti itu memanipulasi kita, bukan sesuatu yang dibawa sejak dia lahir dan sebagainya, tapi suatu hal yang dipelajari bertahun-tahun. Jadi dia terlatih untuk bisa membuat apa yang dia inginkan itu kita penuhi dan bisa membuat kita juga merasa bersatu, suatu hal yang dipelajari. Itu yang berbeda dari diabetes.
So you see, I see this, and I don't have this experience. No matter how smart I am, and no matter how many books I read or whatever, I could only gain this experience if I do what they do. And I don't run the streets. I don't know. I don't want to learn this skill. And anybody who is running the streets of Jakarta or Kuala Lumpur or any other city for 10 years is going to be smarter than me, going to be good psychologist, even despite the fact that I'm a doctor or professor of psychology. He will be a sort of, street psychologist, very good at what he does.
Ya, jadi ini tidak peduli seberapa pintar kita, kalau kita tidak terlatih di bidang itu, ya kita nggak akan menguasai keterampilan tadi ya. Mereka itu adalah orang-orang, boleh dibilang seorang psikolog jalanan, karena mereka tahu gimana caranya menghindar dari polisi, lari ke sini, lari ke situ, cari uang, meyakinkan orang dan sebagainya.
And because they do this for many years, they're not gonna change the behavior and everything. The moment they enter your office, they're going to do exactly the same what they do with other friends. They're going to communicate, they're going to tell you stories, they're going to exaggerate, and etc., etc. And you cannot buy into this, and you cannot fight it, because you're never going to win. They have more experience than you will ever have.
Ya, jadi udah bertahun-tahun dengan keterampilan seperti itu, terus datang ke tempat praktek kita, ya dia nggak akan langsung merubah kan? Ya, dan kita tidak akan mungkin menang, sebab mereka itu ya sudah terlatih gitu loh.
And you just need to be like Jose, you need to be persistent, you need to not engage in the fight, you need to try to change it by, I was telling you yesterday, that you're going to, from session number 1, you're going to apply certain communication skills, but you also will be modeling certain communication skills from them. You're going to be slowly teaching them to not to do what they used to do. You're going to be introducing a different type of behavior. So the counseling session will become a model of new ways of talking to people.
Yeah.
Not making up stories, not exaggerating, and etc. Not manipulating, and not making you do what they want you to do, but following your guidance and doing what you want them to do.
Jadi seperti yang tadi George bilang, Bapak Ibu sekalian, apalagi menghadapi mereka dan untuk pertama kalinya, hindari konflik. Sabar dan persistence. Sebab apa? Kita itu sesi counseling kita akan menjadi model buat dia. Bagaimana caranya kita berkomunikasi dengan orang secara normal. Itu menjadi model buat dia. Pembelajaran buat dia. Oh begini toh. Jadi kita ingin supaya dia tidak berbicara dengan cara yang sama seperti yang biasa dilakukan.
It's going to take a little bit of time. It's not going to happen in the first session. And you need to, and it happens to me over and over. I've been working in this field for many years. I've seen a lot of patients, and still happens to me that a patient comes, tells me a compelling story, and I start feeling guilty or responsible. I have an urge to do something because the patient wants me to do.
Ya, jadi,
what should I do?
Ya, jadi Bapak Ibu sekalian, Marek saja yang sudah 15 tahun bekerja di bidang ini masih juga mendapatkan pasien-pasien yang bercerita dengan sangat menyakitkan dan membuat dia merasa bersalah sehingga kadang-kadang pengen menolong dia lebih daripada yang seharusnya dan sebagainya ya. Jadi Bapak Ibu sekalian, jadi jangan bermimpi bahwa kita bisa meminta berubah dia dalam waktu sekali pertemuan saja.
When I start feeling like this, I tell myself, oh, he or she is very good. Be careful, because she is about to turn you around, and make you do what she wants you to do. Don't do it. This is my internal talking to myself in my head, just reminding Remember, she's good. She has a lot of experience. You don't. Don't do this.
Jadi kalau Bapak Ibu nanti mengalami hal yang sama seperti Marek, jadi udah mulai merasa iba, merasa mikir dan sebagainya, merasa bersalah dan sebagainya, tolong diingat-ingat bahwa mereka adalah orang yang sangat baik, sangat terlatih di dalam hal ini. Jangan sampai terjebak, tapi juga tidak berusaha untuk tidak terus kemudian percaya, tidak. Jadi tetap menerima dia, tetapi tetap percaya, tetap meyakinkan diri bahwa mereka bukan, ya mereka ahlinya.
If you say that it's because the experience, how about if you say that it's because the experience, they are really trained about manipulative. How about if our patients are only several months using it? It would be easier to cure them.
Yes, I'm not saying that. First of all, not every single patient is like that. It's not manipulative. I'm saying it doesn't mean that we're talking about everyone. It means that simply higher proportion. You, like I hear from your own account, that some of the patients are particularly frustrated. That some of them, not everyone is lying, like you said. I'm pretty sure you have the same experience. So yes, you're right. A person who is just started using drugs does not yet have this experience, and likely not to be. But you are not going to see the patient. Trust me. You will not see the likelihood that you see somebody who started using drugs 3 months ago is zero. Actually, the person who just started using drugs will not be eligible for methadone maintenance treatment.
Gini, tadi Ibu Kiki nanya ya.
Yes.
Tadi Ibu Kiki nanya ya. Gimana kalau itu memang suatu hal yang dipelajari, gimana kalau orang itu baru beberapa bulan pakai? Marek meyakinkan bahwa kalau orang itu baru beberapa bulan pakai, sebenarnya dia tidak eligible untuk, tidak layak untuk metadon ya, tidak layak untuk metadon. Dan kalau dia baru beberapa bulan pakai, dia tidak akan mencari pertolongan. Dan sekali lagi bahwa tidak semua pasien kita itu pasti manipulatif. Ya, tidak semua orang dari pasien kita itu pasti berbohong. Pasti ada beberapa itu tidak berbohong. Ya, beberapa tidak.
Another take on the issue whether they lie or not.
Another issue. Sorry.
Another take. I'm going to
jadi
just a couple minutes on the issue of lying. Do they really lie to us?
Jadi kita akan membahas sedikit bagaimana untuk membedakan apakah mereka berbohong atau tidak.
Again, there has been a lot of research in the United States and other Western countries on, for example, on obesity, trying people to lose weight, go on a diet. And what they do, they tell people, they ask people to report how much they eat, right? People who are on the diet.
Ya, jadi ada penelitian tentang orang-orang yang obes ya di Amerika Serikat yang diminta untuk melaporkan berapa banyak mereka makan ya, mereka ini dalam program diet ceritanya.
How accurate do you think the reports of people who have weight problem in terms of the amount of food they consume?
Seberapa akurat menurut Bapak Ibu laporan mereka untuk melaporkan berapa banyak makanan yang dia makan dalam sebulan?
Right, they are not accurate. Which direction? How inaccurate? I mean, do they overestimate? Do they say that they eat more than they actually do, or do they say they eat less?
Ya, jadi kan tidak akurat, tapi kemana arahnya? Lebih banyak melaporkan, ini yang kurang melaporkan.
Why are they lying about their food intake? Why are they lying?
Kenapa mereka berbohong mengenai masalah makannya? They're ashamed if they admit that they lied. Mungkin mereka malu.
Maybe, but most likely this is not shame. There's nothing illegal about eating, right?
Kan ada yang ilegal ya dari faktor makan ya. Kenapa mereka bohong?
We think that, and there has been a lot of studies done showing that these people have a bias. They have self-perception. They have a biased perception of what they do, who they are, how they behave. Chinese thermostat. It works like, cheap Chinese or whatever you call it here, Indian-made thermostat.
Jadi karena saya pukulin melalui kentalnya, kita injeksi terus, apa yang terjadi? Termostat di otak kita lagi udah bukan seperti buatan Jepang atau Swiss, tapi seperti buatan Cina.
And then I ask, does it sound familiar? Do you see any similarities between the story and how you feel? And if I'm very successful, patients say, yeah, this is how I feel all the time. I constantly, I used to never think about heroin or anything, and now I constantly feel uncomfortable and constantly on my mind.
Ya, biasanya kita balikan lagi kepada dia. Gimana menurut Anda? Sama nggak seperti kehidupan kamu? Dan biasanya dari pengalaman Marek, dia pasien akan jawab, ya itu seperti kehidupan saya. Jadi saya terganggu jadinya ya. Karena kita tetap berpikir terus ke sana ya, tanpa bisa berhenti.
So heroin users, if you were to experience heroin dependence, your experience will be following. You will have, even if you actively using heroin, you have those chunks of time, about 20 minutes, that you will be feeling normal. So it'll be 20 minutes of feeling normal, followed by extended period of not feeling normal, not feeling good, and then injecting, feeling high, and you have your 24-hour day, or your day will be divided into the small chunks of feeling normal. Like in this thermostat, when the temperature is between 24 degrees and 22 degrees, it's still comfortable, but it continues to drop down. It doesn't stay there. It goes down, it goes down, goes down, and then goes up and up and up. And then there's a small window where it is normal, but pretty quickly goes up and goes down. So imagine doing anything. Imagine working. Imagine raising your children. Imagine reading a book. Imagine making money. Painting or doing anything where your life is divided to the small windows of feeling normal. Impossible.
Nah, jadi kita di sini biasanya sudah bisa meyakinkan mereka. Coba kamu bayangkan bahwa hidup kamu yang normal itu sifatnya pendek sekali. Jangka waktunya pendek, hanya 20 menit. Kemudian kamu harus pakai lagi drop, kemudian kamu pakai lagi heroin, kemudian kamu merasa tinggi, kamu kemudian hanya normal lagi tapi sangat pendek. Bayangkan kalau dalam 24 jam hidup kamu tuh terbagi-bagi. Yang normal tuh hanya pendek-pendek seperti ini. Gimana kamu bisa mengasuh anak, sekolah, kerja dan sebagainya. Sama seperti termostat ini, kalau dia masih dalam jangka waktu yang dekat dengan 20, kalau kita set 20, dia 22 masih kita enak, 18 masih enak. Tapi ini kan karena dia naik terus sampai 18, sampai 30-an, kita tidak akan merasa nyaman. Atau dia turun sekali, kita tidak akan merasa nyaman. Nah, seperti itulah hidup kamu.
So how do you like this? Is it a convincing story that I'm making good arguments so far? I know you guys getting tired. It's the third day, but just bear with me for a few more minutes. How is the story?
Gimana kira-kira? Gimana dengan cerita ini? Kira-kira bisa itu dipakai sebagai analogi?
Okay, so let's play with the story for a second, for a little bit longer. How do you fix this broken thermostat?
Ya, gimana kita membetulkan itu yang namanya thermostat tadi?
Let's say we have a problem. We have this thermostat that doesn't work, and we still want to learn something. We want to continue doing what we are doing, but this thermostat is broken. The temperature goes from 35 degrees to 15 to 35 to 15. It's very annoying. How do we fix the problem? Huh? Yeah, but how do you change the brain? Really hard.
Jadi ya kita tanya kepada pasien ya gimana kita akan betulkan itu.
How do you repair the brain? Do any of you know how to fix the thermostat? No, I don't know either.
Go to the expert.
Yes, but we can bring an extra small thermostat, an extra additional. Even let this work, but we can borrow a cooler from another room to stabilize. Anyway, I'm going to make it short. And this is the role of methadone. All right, the methadone is a sort of artificial stabilizer that we give people to help them to prevent this wave. So this is one way of thinking of methadone. It's something that we bring in, rather than replacing the brain or fixing the brain, we're bringing in external heater or external cooler, small one, that makes these variations a little smaller. It makes a smaller weight, it stabilizes.
Nah, kita kan tadi tahu ya untuk membetulkan ini tidak gampang ya. Karena yang paling gampang apa bawa aja lagi yang baru ya, atau sesuatu hal yang berasal sifatnya eksternal. Nah seperti itulah kurang lebih kerjanya metadon. Metadon sebagai stabilizer ya di dalam otak kita. Dia tidak menggantikan kerjanya otak, tapi dia menstabilkan seperti halnya termostat yang kita bawa dari luar tadi.
When I explain to patients what methadone is going to do for them, I don't tell them that they're going to go to the brain, attach to the receptor, and maintain steady plasma level.
Ya, kita tidak
That's the wrong work.
Ya, kita tidak menangkan hal-hal yang sifatnya medis ya untuk mempertahankan plasma plasma yang stabil dan sebagainya, kita tidak menanam seperti itu ya.
I started telling them, introduce the concept why they should take the medication, because I start with those windows. You know, I generally able to convince them that their life is divided into 20-minute windows of feeling normal.
Biasanya Marek akan coba meyakinkan mereka bahwa percaya bahwa hidup Anda itu yang normal hanya terbagi dalam berbagai macam bagian yang sifatnya yang kecil sekali, hanya 20 menit.
What methadone is going to do for them is going to take this 20-minute window and it's going to stretch it to 24 hours.
Apa yang dilakukan methadone adalah memperlebar jangka waktu tadi yang hanya 20 menit untuk berpikir normal tadi menjadi lebih lebar, lebih panjang.
For the first time in their life, they will not have 20 minutes to do something. They will have 24 hours to do something.
Ya, jadi untuk pertama kali buat mereka nanti kalau dia pakai metadon ini sudah stabil, maka dia akan mendapatkan kehidupan yang normal bukan hanya 20 menit tapi 24 jam.
And this is why how the role, the combination of medication and your counseling intervention is going to work. If the person is actively using heroin, is running the streets, no matter how much education, how much effort, how much skills you give them, they simply do not have enough time to put it into meaningful change. None of you will be able to function if I give you only 20 minutes at a time, chunks of time to do something.
Jadi sini kita menegaskan bahwa yang namanya intervensi itu bekerjasama dengan farmakoterapi. Karena apa? Kalau dia masih aktif pakai, masih berada di jalanan, yang tadi kan hidup normalnya hanya 20 menit. Apapun yang kita lakukan, seberapapun kita mengedukasi dia, itu tidak akan ada perubahan perilaku. Karena dia pendek sekarang.
Right. But because they are on methadone, the moment they reach the stable dose of methadone, they're going to have a window of 24 hours at least that they don't have to do anything.
Ya, karena metadon sehingga tadi hidup normalnya menjadi lebih panjang ya.
They will feel normal for 24 hours, fine, no problems, no pain. There will be, again, the brain will go back to non-existence.
Ya, jadi otak akan kembali sebagai awalnya.
Anyway, so you see, these are the examples. I do not use with my patient slides unless they are students, unless they are educated, or maybe later on, after I introduce it in the simple models, you can use the slides, but this may not be the most efficient way from the beginning. It may not be the most efficient way to talk to people in Indonesia. You need to come up with your own stories. This story, because we are translating, it takes a longer time. It does not take me that much time, and I usually can keep my patients much more attentive and very quickly. I also make it interactive. I have a direct contact because it's a different situation here. You may not be sold on this story as much as I am, but it worked for me many times.
Ya, jadi Bapak Ibu ini kan kita bahasa diterjemahkan ya. Kalau Bapak Ibu bisa memahami langsung mungkin akan bisa dapat spiritnya ya, sehingga bisa lebih cepat ya. Ini karena diterjemahkan jadi lebih lama sehingga juga mungkin tidak bisa memperoleh apa ya istilahnya ya, pesan semangat utamanya dari cerita itu. Jadi silakan nanti kembangkan sendiri dengan situasi-situasi yang sifatnya lebih lokal. Kalau mau pakai ini tidak digunakan pada pertemuan pertama, kecuali memang dia adalah seorang mahasiswa yang memang pintar dan sebagainya. Kalaupun mau digunakan silakan, tapi tidak di pertama, tidak pada awal ya, karena ini tidak efisien menggunakan slide ini.
I'm going to give you 2 stories, very short. They will be much shorter, and you will not be. I'm going to tell the whole story, and then you translate the whole story because they are very simple. And I think I mentioned. So in Malaysia, sometimes when I talk to fishermen, I ask them about the stormy sea and going fishing. You were not there. So I ask the patients in Malaysia who are fishermen, can you go out and fish, catch a fish, support yourself, sustain your family when there's a storm out in the sea? They say no, it's hard, it's dangerous. It's exciting to sail in the deep waves, but it's not good for fishing, for sustaining family, for making money. Calm sea is good. So what methadone is going to do for you is going to calm the storm. So now, because you are using heroin, you have a storm going on, and the methadone is going to make a flat sea for you, so you can go out in your boat and fish, catch some fish, feed your family, or sell it on the market, and make your life better.
Ya, ini ada contoh di Malaysia, mamanya waktu itu Marek menghadapi seorang pasien yang dia adalah seorang nelayan tentang ikan. Dia akan tanya kepada si orang ini, bisa nggak sih kamu ngambil ikan kalau ada badai besar? Orang itu menjawab tidak bisa. Jadi apa harus kalau lakukan? Kalau itu adalah kalau lautnya tenang. Nah, metadon itu digunakan untuk menenangkan yang namanya badai tadi, supaya tidak, karena kalau dalam badai memang menantang, mungkin juga sangat menggairahkan, tetapi kamu tidak akan banyak mendapatkan ikan. Lain halnya kalau sesuatunya tenang. Nah, metadon dipakai untuk menenangkan badai itu tadi, supaya ikannya bisa dapat lebih banyak.
Okay, in China, when I go to China, I tell them the story about Chinese New Year. Imagine a situation that somebody gives you a sewing machine with an instruction, and you want to learn, you want to open the shop where you make clothes and sell in order to make your life better. But you never use this. This is electric sewing machine that comes with the instruction, and you want to learn, you read this instruction. But there's no light. The only light, there's a Chinese New Year and there's fireworks, a lot of fireworks going on. So you're sitting by the window and you're trying to read the book by the fireworks. And so every minute or so, there's a big splash, colorful splash, you have the light, you read a couple of sentences, and then there's dark. And then you wait, and again, there's another big firework explosion, you read another couple of sentences, and then it goes dark. How easy for you to learn how to sew? Not easy.